Hello.
Good morning.
Good morning, good afternoon, good evening. It's Malka Stromer
And Janine Noble.
from Sound Sports Imaging. Thank you for joining us today on today's webinar on first trimester point of care ultrasound. We're going to be talking about just that. And if you have any questions, you can be sure to save them to the end of the class, and we'll try to answer all of your questions. And so let's get started. Okay. We are going to be talking about first trimester ultrasound. The goals of first trimester ultrasound are listed here. It's very important for us to be able to visualize and localize the gestational sac and determine whether it's intrauterine or not. We can identify early embryonic demise. It's vitally important at this stage in the first trimester to identify the number of embryos and if there is any risk of embryonic or fetal demise. Determine the number of embryos for looking at chorionicity and amnionicity in multifetal pregnancies. As the gestation gets older, it gets much more difficult for us to determine chorionicity and amnionicity. And this is vital for us to be able to follow the pregnancy, or the OBGYN to follow that pregnancy well. We can estimate the gestational age of the pregnancy, and our measurements that we take on ultrasound in the first trimester are the most accurate. So we want to be able to determine gestational age in the first trimester if we can. We can also look at abnormal yolk sacs and early diagnosis of fetal abnormalities and any abnormal embryos actually in the first trimester as well. So, first off, we want to look at something known as the double decidual sign. Now, the decidua is actually just another term for the endometrium, and the endometrium in and around the implantation. So the double decidual sign is the ultrasound visualization of all three layers of the decidua. The decidua capsularis, the decidua vera, and the decidua basalis. If we are able to visualize all three layers of the decidua, this is confirmation of an intrauterine pregnancy. I say here that it rules out an ectopic just based on statistics alone. You could have heterotropic pregnancy, however, statistically, that is very rare. But if we are visualizing a double decidual sign, that is evidence of an intrauterine gestation. So we have some images here where we can actually visualize all the layers of the decidua. You can see this area here where the decidua appears to be thicker. That's actually the area where the placenta is growing, and the decidua basalis. These images here, on these two, these are all transvaginal ultrasounds. These images here are what we call a decidual cast, and it is actually not a double decidual sign whatsoever. You are not visualizing all of the layers at all. You can actually see that the endometrium is quite thin all the way around. This decidual cast, oftentimes we see with ectopic pregnancies, because a pregnancy is a physiological process that will take place. And so you may get some appearance of fluid. There will be fluid sometimes because of bleeding in an ectopic pregnancy, and give that pseudo appearance of a double decidual sign. So it's very important to be able to distinguish and decipher if we're visualizing all three layers of the decidua or if we're not at all. And it gives us that pseudo double decidual sign. In ultrasound words, we call it a decidual cast. When we need to identify fetal membranes in the first trimester. And the chorion is the gestational sac. It is the outer membrane that we can visualize. And the portion of that chorion that actually is rooting, it produces these what we call villi or chorionic villi that invade into mom. That is the villus chorion. And then as the chorion actually grows out, it will actually, and meets the decidual capsularis, it will actually become smooth. All those finger-like projections will smooth out, and so we'll have what we call a smooth chorion and then a villus chorion. And it's quite cool because on ultrasound, you can see those little villi all the way around. And this is actually taken an embryo in a water bath. And so giving you that perspective of when that gestational sac grows to meet the decidua capsularis, then those villi will actually get flattened, whereas the other villi will persist in the decidua basalis. So the outer membrane is the chorion or gestational sac. We'll then see the amnion, and the amnion is a thin membrane surrounding the embryonic disc, and we should see it by 6 weeks gestation. It grows rapidly and extends outwards towards the chorion. It will eventually meet the chorion and fuse with the chorion, okay? The yolk sac is a structure, it's the primitive nutrition to that developing embryo. And the yolk sac is in between the amnion and the chorion. And so once the amnion meets the chorion about 12 weeks, that yolk sac gets smushed. And then there should be fusion of the amnion and chorion by week 16. So here are a couple of images here of those membranes. Okay, these are, again, both transvaginal images. You can see the high quality visualization of the structures. So this outer membrane right here is the chorion or gestational sac. And then there's chorionic fluid. You can actually see that chorionic fluid can sometimes be a little bit more viscous and thicker, and so that's why you may see some more echoes in that chorionic fluid. The inner membrane here is the amniotic membrane. And then in between those two membranes, we have another circle here, which is the yolk sac. The embryo should be within the amniotic sac, okay? And so if we're looking at this image right here, on the top left of the PowerPoint screen here, you don't see an embryo, but it's vitally important that we don't just take one image. The ultrasound, remember, is one slice at one point in time that you're imaging. We need to be dynamic and scan through that gestational sac from left to right, superior to inferior, in order to visualize the contents of that gestational sac. So this image here was acquired to show the membranes, and if we scan through, we'll see the embryo in another angle and a section of that amniotic sac. So here's a real image here displaying, again, just what we showed you on ultrasound, the outer membrane, the chorion, having those villi, those finger-like projections. We have an inner membrane called the amnion. The embryo lies within the amniotic sac, and there's the primitive nutrition of the yolk sac that is in between the amnion and the chorion. So as the amniotic sac grows, it will eventually meet the chorion, and this yolk sac will be destroyed. And that happens at 12 weeks. And what else happens at 12 weeks is the placenta takes on its maturity and takes over the lifeline to the baby. This image here is actually an image showing the vitelline duct, which is the connection of the yolk sac to the embryo. So you can actually visualize the vitelline duct as well as the yolk sac, which is quite interesting. So the American College of Radiology specifies the requirements for first trimester ultrasound, and that is visualization of our gestational sac, looking for a yolk sac and or embryo. If there is an embryo, we want to measure what's called the crown rump length. We want to see if there's any cardiac activity. Again, vitally important is for us to be able to determine fetal number and therefore determine what we know as amnionicity and chorionicity. Vital and important in the first trimester, as it becomes a lot more difficult as the gestation grows. And it's important for the care of that pregnancy and those pregnancies as we move forward. And as well, even though we're looking at the pregnancy, this pregnancy is within mom. And it's important for us to also be sure to look at uterus and adnexa, because there may be some pathology there, such as fibroids or maybe a tumor that may affect the progression of the pregnancy and delivery methodology and stuff like that. So always remember, even though we're looking at baby and our prime focus is baby, we also want to scan through the uterus and adnexa to be sure that everything else looks nice. So these are just some images here looking at a normal endometrium prior to implantation. So we can visualize different thickenings of the endometrium based on where a woman is in her cycle. So oftentimes in a very early pregnancy, 3-4 weeks, all we may visualize on ultrasound is a nice thick endometrial canal and stripe. We may not visualize, it may be too early for us to visualize the first thing, which is the gestational sac within the uterus. And so we have to correlate dates very importantly when we're doing first trimester ultrasound. Okay, so here is an image here displaying a nice thick endometrium and a little, what appears to be, looks like almost a little cyst within the endometrium. That is the gestational sac, and that's only at 4 weeks, 3 days. The ability for us to pick up early gestation is a lot better when we do transvaginal ultrasound, because we can use a higher frequency transducer because we're closer to the organs. So transabdominally, we may not have been able to visualize this at all that early, but that's the first thing that we'll see is a gestational sac, and we should always pick up a gestational sac at 5 weeks, 2 days. Okay, if we're not, we may question the dates that are taking place, or if there may be a miscarriage that's taking place or something else. So we probably want to follow it up in a week to see if that is there and correlate that with biochemistry, HCG levels, etc. This image here is actually us looking at 3 different echoes here within the endometrial canal. So we have that inner amniotic cavity, we have an outer chorionic cavity, and you can again see that there's different echoes between the chorionic cavity and the amniotic cavity just because of the viscosity of the fluid. And then behind that is actually, it's labeled here SCH, and SCH stands for subchorionic hemorrhage. This is fairly common in pregnancies, that there may be some bleeding. There may be implantation bleeds or bleeding behind the chorion. Typically they resolve on their own. It's important for us to document if this is taking up a large percentage of the chorion. And it's also very important to decipher the difference between this and an abruption, which clinically is very, very different. So we would just follow up a subchorionic hemorrhage. When looking in the first trimester, in order to pick up gestational age, we can do several measurements. And one of those measurements is the gestational sac size, or mean sac diameter. And what that is the sum of 3 orthogonal dimensions of the gestational sac divided by 3. Now, we don't have to go out and pick up a calculator and do this. Our machines have calculation packages that if you plug in your length, your width, and your AP dimension of the gestational sac in an obstetrics package, it will pop out a gestational age. For example, on the right here, you can see there's 3 different dimensions, and the gestational age here correlates with 7 weeks and 1 day. So based on our knowledge of that, we should obviously also be able to see a embryo with a heartbeat at 7 weeks, 1 day. So we want to correlate all these measurements. The first structure visualized within the gestational sac is actually the yolk sac. And the number of yolk sacs determine amnionicity. So it's also a helpful factor if we're looking at multiples. So we want to be able to visualize that nice yolk sac. Again, we can visualize the vitelline duct if applicable. You can see this image here is showing us an image with power Doppler. So power Doppler is looking just at flow. There's no blood flow within the yolk sac. And the ultrasound terminology for visualization of the amnion as well as the yolk sac is something that we call the double bleb sign. So in this image here, we're visualizing amnion as well as yolk sac together. That is called the double bleb sign. Abnormal yolk sacs are those that are over 5.6 millimeters between 5 and 10 weeks gestation, and it's always associated with an abnormal outcome. And you can see here that just by visualization, there's no measurements on this yolk sac, but here is this outer portion here is the gestational sac, inner amniotic sac. You can actually see a fetal pole here. This is the yolk sac. The yolk sac is almost, in my eye, at least half the size of the amniotic sac. And it's a very big, so without even putting measurements on there, you can see that that's a large yolk sac. And again, there's power Doppler being put on here. The reason being is they were looking for a heart rate, a heartbeat. And you can see that there's no blood flow within that that embryo, and so that was a bad outcome for that pregnancy. And just the indicator of the large yolk sac would lead that that practitioner to be able to make that determination. Here's another one. Here's a very large, this is 5.9 millimeter yolk sac. There's also a calcified yolk sac, which is this image here on the right. You can see that there's this bright white circle next to the embryo that's being measured. And calcified yolk sacs are only seen with, unfortunately, dead embryos. And that makes sense because, again, the yolk sac is the primary nutrition and support for that developing embryo until the placenta takes over. And so, therefore, if it's calcified, it's not functioning anymore. And therefore, unfortunately, that embryo will not be able to take. The fetal pole should be visualized by the time there's a mean sac diameter of 16 millimeters. So you can see here, this image here is measuring the fetal pole, and we call that measurement the crown rump length. That measurement here is 2.5 millimeters in size, super small. But that correlates with a gestation of 5 weeks and 5 days. And not only does that that fetal pole here exist, but there is also the initiation of a heart rate. And you can see here that that heart rate here at 5.5 weeks is 107 beats per minute. Now, a normal heart rate typically throughout a gestation is about 120 to 180 beats per minute. So obviously this is low. However, this is just kind of the initiation of that heart pumping away and blood flow. And so if we follow it up in a day or two, you can see that this is now an image of a fetal pole that correlates with 3.1 millimeter crown rump length, correlating with 6 weeks, 0 days. And now the heart rate is 141 beats per minute. And I like to use heart rates if we're actually visualizing. You can see a little flicker visually with grayscale of that heart rate, but I like to use a lower power output of M mode. You can see a motion mode here. You can see the vibrations of that heart in there. A lot better than using power Doppler or color Doppler. These are rapidly developing cells. You want to use your ALERA principle as low as reasonably achievable, so there's no negative outcomes with the use of ultrasound. So just to refer back, in the first trimester, we are going to be taking some measurements to determine gestational age, and it is the most accurate time for us to take measurements and correlate that with gestational age in the first trimester. As the gestation grows, if we follow it in the second trimester into the third trimester, the accuracy of the measurements go down. And so if we can scan a pregnancy in the first trimester, those measurements are the most accurate, and it's really good for follow-up of the pregnancy as we proceed forward. So the measurements that we typically take in the first trimester, again, are the mean sac diameter, which I just displayed to you, the crown rump length, which I'll show you, and sometimes, depending on the size, we can do the biparietal diameter. But typically, that's only can be used at the end of the first trimester when that measurement reaches about 20 millimeters. Other than that, it's not accurate. It's a measurement then we'll take to the second trimester. So here's an example of the crown rump length. It's a measurement of the fetal pole from the top of the baby's head to the baby's rump or bottom, excluding limbs. So you can see here, we're measuring from the top of the baby's head to the baby's rump. You can see some little arm buds here, so we're not including those in the measurement. We're just going from head to rump. Ideally, you would like to get the embryo or fetus into a nice neutral position and not curved into that true fetal position as well. Because if that embryo curves into a fetal position, then your measurement is a little bit off and not as accurate. So I like to do probably about 2 to 3 measurements just to make sure that we're consistent in the best that we can. And so here are a couple of examples of fetal poles. Here's one at 6.5 weeks gestation, one at 8 weeks gestation, 10, and at the end of the first trimester. You can see the progression of what looks like a little peanut into what now looks like an actual little baby, actually, at the end of the first trimester. Here's another example here of a crown rump length that we can take from the bottom to the top of the baby's head. You can actually see the feet dangling up in the air there. This is a great image, and if you take a true midline sagittal image of that fetal pole, you'll also be able to acquire a nuchal translucency measurement at the appropriate stage in the pregnancy. It's typically 11 to 14 weeks that we would do that, and also be able to pick up nasal bone as well if you're doing some first trimester genetic ability. And the last measurement that we can take, again, not as accurate necessarily, but I'll show you what it is. It's called the biparietal diameter. So we're measuring from parietal bone to parietal bone. And what we do is we put our caliper from the outer portion of the parietal bone to the inner portion of the opposite parietal bone. Again, most accurate at the end of the first trimester if we do use it, but it's typically about 20 millimeters or more when we can use that in a measurement of gestational age. So we'll take all these measurements, put them together, correlate that everything is accurate. I put some little stars here to show outer portion of parietal bone to inner portion of parietal bone. If you have any questions, please let us know now, or if you have some later, you can send those to info@soundsportsimaging.com. You can also visit our website at www.soundsportsimaging.com. I'd like to credit Rumack, Wilson, Charbonneau, and Johnson Diagnostic Ultrasound text for a lot of the images today. My mentor, also Dr. Stephanie Wilson. So thank you all for joining if you don't have any questions. And remember that Sound Sports Imaging provides solutions to all your ultrasound needs. Have a great day.
Bye.